Hi, my name is Ricky Graves, and I'm happy to introduce Dr. Kevin Daly. Dr. Kevin Daly is a pediatric cardiologist in Boston Children's Hospital, specializing in heart failure and transplantation. His clinical work is focused on the evaluation and management of children with advanced heart failure and those requiring mechanical circulatory support and/or heart transplantation. He's also a translational researcher focused on the development of biomarkers and novel imaging technologies, which will allow for non-invasive diagnosis of cardiac allograft vasculopathy. Dr. Daly is a clinical expert in the diagnosis and management of the highly sensitized pediatric heart transplant patient and those who develop antibody-mediated rejection. He's published his center's experience with perioperative desensitization for cross-match positive heart transplantation and utilized two different drugs, a terminal complement inhibitor and a proteasome inhibitor for the treatment of antibody-mediated rejection. He's the only transplant physician in this group to perform an intracardiac hemodynamics, endomyocardial biopsies, and coronary angiography in transplant patients and have expertise in the diagnosis of CAV. Dr. Daly has demonstrated that VEGF-A can be used to stratify risk for development in CAV in children after heart transplantation. He's planning a prospective study to determine if VEGF-A testing can safely reduce the frequency of invasive coronary angiography procedures in pediatric heart transplant recipients. In addition, he's leading a multi-center collaboration to design and perform the first randomized controlled trial of maintenance immunosuppression in pediatric heart transplantation. His team expects this trial will support the first FDA-approved indication for maintenance immunosuppression in pediatric heart transplantation. With that, I will turn it over to Dr. Daly. Welcome.
Hi, thank you so much for that introduction. And I am really pleased to share with you the preliminary results from the TeamMate trial, which was focused on whether or not everolimus could prevent rejection in children after cardiac transplant. I have about 20 minutes of content, and the goal was to leave about 10 minutes at the end for questions. So hopefully, even with the late start, we can get to some questions. So just for some background, which many of you already know, heart transplant is considered definitive therapy for children and young adults with end-stage heart failure. The primary strategy to prevent rejection in children and young adults involves a combination of tacrolimus and mycophenolate mofetil. Everolimus, which is a proliferation signal inhibitor, has been shown to reduce the risk of rejection, cardiac vasculopathy, renal dysfunction, and CMV infection. However, there are some concerns because adult studies showed a higher risk of death due to serious infection when initiated early after heart transplant. However, it is unknown whether everolimus is safe and effective when introduced at 6 months post-transplant in children and young adults, a population with an otherwise relatively long life expectancy in the absence of developing transplant complications. So the primary goal of our study was to evaluate the safety and efficacy of everolimus and low-dose tacrolimus to prevent rejection, vasculopathy, and renal dysfunction in children and young adults when introduced at 6 months after heart transplant. The secondary goal was to reduce the off-label use of anti-rejection medicines in children by obtaining FDA approval for pediatric heart transplant recipients, because none of these medications were approved at the time the TeamMate trial was launched. Our methods. So we did a phase 3 open-label randomized clinical trial conducted at 25 sites in the United States. We included patients who survived to 6 months after heart transplant, were less than 21 years of age, and on stable immunosuppression. They had to have planned follow-up at the study site. In order to maintain safety, we excluded several high-risk patients, including those with recurrent rejection or graft dysfunction, those on high-dose steroids, those with particularly poor renal function, those with active infection or wound healing problems, and those with severe hyperlipidemia or proteinuria. Finally, we excluded patients who were known to be non-adherent with their medical therapy. This is the general diagram for our study. So you can see it started at 6 months after heart transplant. There were 2 arms, which patients were randomized into, which means assigned at random after being enrolled. They were either given tacrolimus with mycophenolate mofetil or CellCept. The tacrolimus goal was 7 to 10 for the first 6 months of the study, and then dropped to 5 to 8 for the remainder of the study. The investigational arm was everolimus with low-dose tacrolimus. The everolimus goal was 3 to 8, whereas tacrolimus target was 3 to 5 for the first 6 months of the study, dropping to 2.5 to 4.5. The appropriate regulatory oversight was in place. We collected graft loss events and serious adverse events, as well as adverse events, at 8 study visits. We performed coronary angiography at 2 study visits, and the primary endpoint was the MATE score. So what is the MATE score? This is the Major Adverse Transplant Event Score. It is composed of 6 serious adverse transplant events, including chronic kidney disease, coronary disease, cellular rejection, antibody-mediated rejection, infection, and post-transplant lymphoproliferative disease. Within each event type, they were graded from none to severe, and we created an ordinal endpoint that could be summed up in order to increase statistical power. The first 3 events were composed or included in the MATE-3 score, so kidney disease, coronary disease, cellular rejection, and all 6 events were included in the MATE-6 score. We have previously published that patients with a higher MATE score are at increased risk of loss of their transplanted graft. As you can see, the higher the MATE score, the more likely it is that they will lose their graft in follow-up. We also included adverse event reporting so that any adverse events that occurred with any organ system would be reported. This table on the right shows the general gradation. So milder transient experiences which don't require special treatment. Moderate are those that require some level of treatment, but usually don't rise to the level of hospitalization. Severe tend to be events that require hospitalization and significantly interrupt the usual daily activity. 4 were life-threatening or disabling events, and 5 were death. Finally, we looked at, this is the teammate cohort and what happened to our group. So 722 patients were screened for eligibility. 511 were excluded, 320 because they were ineligible, and 179 because they did not give consent to participate in the study. In total, 211 patients were randomized, 107 were assigned to the everolimus group, and 104 to the MMF group. Loss to follow-up was rare in the study cohort, and 80% of patients remained unassigned treatment in both groups. Here is the baseline characteristics by treatment group. The average age was about 7 to 9 years. 1 in 5 patients in the everolimus group was an infant, whereas 1 in 10 patients in the tacrolimus MMF group was an infant. About half were female, and 80% were white. 22 to 28% were Hispanic, and about half were on public health insurance. As you can see, about half of them had cardiomyopathy as the cause for their heart transplant, and the other half was primarily composed of congenital heart disease with the occasional retransplant. About 1 in 3 patients in both groups was on a ventricular assist device at the time of transplant, and 1 in 10 patients was on ECMO. Almost all patients, 90%, received induction therapy, and occasionally patients had a positive T-cell crossmatch. About 1 in 5 to 1 in 4 patients had rejection prior to randomization, and 1 in 10 patients had DSA, donor-specific antibody present. Renal function and heart function was excellent by ejection fraction and GFR. This was our primary safety endpoint, the MATE-6 score. Graphed on the left is the total cumulative MATE score for the entire study group over time since randomization. The everolimus group is represented in red, and the tacrolimus MMF group is represented in blue. When we compare this on a per patient basis, the average MATE-6 score in the tacrolimus MMF group was 2.2 compared to 1.96 in the everolimus group. From prior agreement with the FDA, what we did was we constructed a 95% confidence interval. And we said, looking at the difference between the 2 groups, what is the likelihood if we did this trial 100 times? What is the group 95 of those times? What would be the expected difference between the treatment groups? The average difference was what we found in our study, which was negative 0.2 favoring everolimus, but a reasonable range of expectation was negative 1.5 favoring everolimus to positive 1.1 favoring tacrolimus or MMF. We had pre-specified that if this difference was less than 3 favoring tacrolimus, we would conclude that the two groups were equally safe. As a result, we felt comfortable concluding that there was no higher burden of major adverse transplant events in the everolimus group compared to the MMF group. And so everolimus meets the pre-specified safety criterion for success. We then looked at our efficacy endpoint, which was a combination of coronary disease, kidney disease, and cellular rejection. Again, you see the population total for the MATE-3 score is lower in the everolimus group compared to the MMF group. When we do our statistical comparison, the MMF tacrolimus group had a MATE score of 1.25, and the everolimus group had a score of 0.93. We performed a test called the zero inflated Wilcoxon p-value, and to meet statistical significance, this value has to be less than 0.05. As you can see, this was trending towards 0.05, but it did not meet statistical significance. So what we conclude is that this difference could be explained by chance as opposed to a true treatment difference. And so at 30 months, the cumulative burden of cardiac allograft vasculopathy, kidney disease, and cellular rejection is not different in the everolimus group compared to the MMF group. We then looked at a pre-specified secondary endpoint, which was the MATE-3 score plus CMV infection. As you can see, again, the everolimus group was lower than the MMF group. We performed a similar comparison between the MMF group and the everolimus group, and this time the zero inflated Wilcoxon p-value was less than 0.05. And so we concluded that at 30 months, the cumulative burden of graft vasculopathy, kidney disease, cellular rejection, and CMV infection was 30% lower in the everolimus group compared to the MMF group. We then looked at a number of key secondary endpoints, including the glomerular filtration rate, which is kidney function. As you can see, in general, it was high in both groups. It was higher at the start time points, statistically in the everolimus group early in the study, but by the end of the study, the difference had diminished to the point where it was no longer statistically different. We then looked at anti-HLA antibodies, which you can see at 6 months after randomization and 30 months after randomization were higher in the tacrolimus MMF group compared to the everolimus low-dose tacro group. We looked at a number of other key laboratory differences. As expected, the total cholesterol was higher in the everolimus group. This is a molecular effect of everolimus that has been well reported. In addition, triglycerides were higher at 6 months and 30 months. Proteinuria is something that's been reported with everolimus. So we looked at the protein to creatinine ratio, and there were no differences in measured proteinuria between the two groups. ALT, which is an enzyme released by the liver if there is low-grade damage, was slightly higher in the everolimus group, though the number of patients with clinically important liver damage was not different and was actually very small in both groups. Overall, the number of adverse events experienced by patients in the TeamMate trial was high. This is not unexpected, but an average patient, a median patient in the everolimus group experienced 7 adverse events, and in the TAC-MMF group, it was 6 events. If you look at the median or the number of serious adverse events, the average number was 2 in both groups. We then break down the adverse events by treatment group. On the left 2 columns, you see the total number of events. The next 2 columns over are the percentage of subjects experiencing a given event. As you can see, the number of adverse events was similar between treatment groups, affecting 95 to 96% of patients in both treatment groups. When looked at serious adverse events, they were approximately equal, with 217 and 213. But when you look by the percentage of subjects experiencing serious adverse events, it was slightly higher in the everolimus group at 70% compared to 57%. If you break it down by the severity grades, which we talked about earlier, there were no statistically differences between the treatment groups. The last group looks at unexpected or possibly related group events, which did occur in both treatment groups, but were not statistically significant. Here we break down adverse events. This is the total number by system, organ, class. So we're trying to understand what types of adverse events are occurring in the trial. The graph at the bottom shows time to event. So the number of events you can see cluster soon after the beginning of the trial and decrease over the time course of the trial, but do not go to zero. Infections and infestations were by far the most common events, occurring in 200 to 300 patients in each treatment group. Not patients, I'm sorry, events in each treatment group, because patients could experience more than one event. However, in terms of which ones were statistically different between treatment groups, there were an increased number of respiratory, thoracic, and mediastinal disorders in the tacrolimus MMF group. There were an increased number of blood and lymphatic system disorders in the tacrolimus MMF group. And there were an increased number of oral ulcers, otherwise known as aphthous stomatitis, in the everolimus group. When we look just at serious adverse events, in general, the same principles hold. The only thing that's different is that nervous system disorders were statistically higher at 11 events versus 2 events, and higher in the everolimus group. When we look at selected adverse events, you can see that anemia was slightly more common in the TAC MMF group, which did not reach statistical significance, as was thrombocytopenia. Rash occurred about in 1 in 5 patients in both groups. Aphthous stomatitis or oral ulcers occurred in about 1 in 3 patients in the everolimus group, compared to 7% of patients in the TAC MMF group. This was statistically significant. Interstitial lung disease occurred in about 13 to 15% in both treatment groups and was not statistically different. We then looked at why patients came off of medication to help understand which of these events were so serious as to allow for or to necessitate withdrawal of study drug. As you can see, 5 patients in the everolimus low-dose TAC arm never even started assigned study treatment. They were analyzed as if they were on treatment the whole time, because that is how you run a randomized trial. However, 3 families declined to change after they were randomized. 1 developed PTLD prior to starting assigned treatment, and 1 was unable to get insurance coverage for everolimus. Other reasons for drug discontinuation. In the TAC MMF group, it was usually persistent rejection in 8 patients or GI symptoms in 5 patients. In the everolimus group, it's much more distributed, but chronic infection was higher at 4 patients. When we look at really serious events, you can see that there was 1 patient who developed bronchiolitis obliterans in the everolimus low-dose TAC group, 1 patient who developed ITP in the TAC MMF group, and 1 patient who developed severe chronic kidney disease. There were 3 patients who discontinued due to patient and family preference. I'm going to move on and talk about the impact of psychosocial factors on transplant outcomes in my last few minutes. I think this is really important for this group in particular to hear. We looked at social determinants of health, particularly race and ethnicity, type of medical insurance, and something called the Child Opportunity Index. It's a nationally normed index based on US Census data derived from domains including education, health, social, and economic. Patients are classified into 5 quantiles: very low, low, moderate, high, and very high. For the purpose of this analysis, we grouped very low and low and high and very high together. We looked at the MATE-6 score for most of these analyses. When you look at the Child Opportunity Index, you can see that the patients were distributed fairly equally as expected between the very low, moderate, high, and very high. You would expect this to be 40, 20, and 40, and it pretty much is. You can see the Child Opportunity Index was highest in Asian patients, followed by white patients, lowest in Hispanic patients, and Black patients. Unexpectedly, it was higher in patients with private insurance compared to those on Medicaid. When we look at the MATE-6 score, according to social determinants of health, The MATE-6 score was highest in Black patients, followed by Hispanic patients, and then white patients and Asian patients. In addition, when we look at the MATE-6 score by the Child Opportunity Index, the MATE-6 score, more major adverse transplant events were occurring in patients with low or very low Child Opportunity Index. In addition, it was higher in patients on Medicaid versus private insurance. When we look at the white and Asian patients and look at the gradient of the MATE-6 score by Child Opportunity Index, we see a lower MATE-6 score in white and Asian patients with a high or very high Child Opportunity Index compared to those with a low or very low Child Opportunity Index. However, when we look at Child Opportunity Index in the Black and Hispanic patients, there is no gradient. As a result, the high and very high COI patients in this group experience as frequent major adverse transplant events as those with very low COI groups. There are some limitations that we need to keep in mind when analyzing this data. There was a lower event rate observed in the trial cohort, which may have impacted power. So we expected more MATE events. There was a higher rate of cardiac vasculopathy than previously reported in the literature. The COVID pandemic occurred during the study and created challenges related to protocol adherence. Adverse events were reported by teams at study sites. Reporting of some minor clinical or laboratory events may have been missed, and only MATE events were independently adjudicated. Finally, COI may change over the course of 2.5-year follow-up. In conclusion, everolimus combined with low-dose tacrolimus is safe in children and young adults when initiated at 6 months after transplant. Everolimus was not associated with a lower burden of coronary disease, rejection, and kidney disease, but it was associated with a lower burden of those MATE-3 events when CMV infection was included in the MATE score. A pre-specified adverse events were universally present after pediatric heart transplant, with the median patient experiencing between 6 and 7 events over 30 months of follow-up. Infection was the most common adverse event, and serious adverse events occurred in 2 out of 3 teammate patients. The rate of drug discontinuation was similar across treatment arms, 1 in 5 patients. Stomatitis was more common with everolimus, while blood disorders and thoracic respiratory events were more common with MMF and tacrolimus. Black race, Hispanic ethnicity, and lower socioeconomic status were associated with more major adverse transplant events following heart transplant. I want to acknowledge that this was a tremendous team effort involving 25 heart transplant centers across the US. You may see some of your transplant cardiologists on this list, and these are all the study coordinators, the Data Safety Monitoring Board, and all the other people that made the study a success. It was truly a team effort. I want to thank the United States Department of Defense for funding this trial to the tune of about $10 million. And I want to acknowledge that it is for you, the heart transplant recipients and their families, for whom we do and dedicate this work. I'm happy to take any questions. I have a couple of backup slides there you see at the end.
Dr. Daly, you can see that there's a question in the Q&A. I can read it to you if you like. Daniel Holden asks, great to see these results. How do you see institutions transitioning to this as the new standard regimen, if at all? Will these decisions be handled on a case-by-case basis? Will they be proactive or reactive decisions, i.e. with the onset of CAV? And again, if there's any, if any of you feel have any other questions to ask, please put them in Q&A. Thank you.
Yeah, perfect. So I think that these, the data is clear that we have 2 regimens which are safe. I think we can say that clearly. There is a high rate of adverse events with both anti-rejection regimens. In terms of looking at efficacy, when we looked at what we had defined as our primary efficacy endpoint, we could not say that everolimus was superior. However, when you add in CMV infection, everolimus and low-dose tacrolimus was superior. So overall, I think we can say we have 2 safe regimens, which are mostly very effective Though we can, well, I'm always welcoming more newer or better drugs for this treatment. So I think it would be reasonable at 6 months to proactively switch to everolimus and low dose tacrolimus. You want to try to do it before CAV develops, because the adult data shows that that the earlier you start it, the better you are at preventing the development of CAV. Now, would it be reasonable to stay on tacrolimus and CellCept if you're doing well and don't have many side effects? That would be reasonable. And I think one of the things we learned from the trial is many teenagers did not want to consent to participation in the trial. They said, well, I already feel good on tacrolimus and CellCept. Why would I switch and potentially develop a different set of side effects with my medications? So that's one approach. I see something in the chat briefly about sirolimus and tacrolimus. So we did not study sirolimus, but so we have to be really clear. Tacrolimus is a calcineurin inhibitor. It works entirely differently than sirolimus and everolimus. Sirolimus and everolimus are proliferation signal inhibitors, or sometimes called mTOR inhibitors. These drugs are actually almost identical. There is a difference of one hydroxyl group between these two drugs. There are slightly different pharmacokinetics, and we did study everolimus. That said, it is not unreasonable to extend these findings from everolimus to sirolimus. The one place where we have to be careful is that the target drug levels are not going to be exactly the same for sirolimus and everolimus, and we did not study target drug levels for sirolimus. I didn't really touch on formulation, but that's important as well. Everolimus only comes as a tablet. For infants and children, we actually used a syringe to crush the tablet. We drew the tablet up in water. We let it sit on the counter for about 10 minutes, and then we administered it to infants. So there's no liquid suspension available for everolimus. However, we did study a way to safely administer it to children who needed a liquid.
Dr.
Looks
Daly,
like somebody asked about long-term monitoring. So, we will not have the same degree of adverse event monitoring for all patients, but we do intend to look at 5-year data and 7-year data. One of the things that will happen is patients will fall off assigned treatment over time. We saw about 1 in 5 patients were no longer on their assigned treatment by the end of the study, and we expect by 5 or 7 years that number will actually increase. However, our hope and our goal is to use the Pediatric Heart Transplant Society database as well as internal data to collect information about major adverse transplant events so we can get an idea about the long-term effects of these drugs.
Dr. Daly, Taylor was asking about CAV, everolimus and CAV prevention. That was up the top.
Yeah. So there are some benefits to it, especially published in the pediatric literature, about preventing CAV even when initiated late. But the adult data, especially using intravascular ultrasound, which is a very sensitive way to look at whether or not the coronary arteries are starting to thicken, did demonstrate that the earlier you start it, the better. And when you start it late, you may slow the progression, but the benefit is not quite as strong. I think that there's a clear role, that said, if you develop CAV to be on either sirolimus or everolimus. I think there are significant advantages as long as your child or you can tolerate the medication. That said, this study does provide some interesting data that would continue to suggest that proactively starting this drug early may actually benefit people overall. I guess the one last thing I would mention is we were pretty specific about our inclusion and exclusion criteria. And so if you're a patient who had recurrent rejection or really bad kidney function, you weren't eligible for randomization. And so you need to be careful about extrapolating this data or applying this data to those patients that weren't included in the study. I would be happy to answer any questions about this. You can send it through Transplant Families, and Joseph knows how to reach me.
Thank you, Dr. Daly. We are over time. Apologies for a late start. So we encourage everybody to join the Lab Values 101 session, which is already in progress. That recording will be available later in case you do want to see that. The presenter is live. And we will also have a heart-specific Lab Values session in about a month or so with the Stanford team. So please feel free to join us in the other room. Thank you very much, Dr. Daly.
Thank you.